Here today is on chronic care management, overcoming some barriers and challenges. Our speakers today are going to be Dr. Joelle Vlahakis, who is our contractor medical director. I'm going to turn the presentation over to Dr. Vlahakis. Give us 1 second while we get the, let her share her screen. Okay, Joelle, this is available for you now. We are ready to begin whenever you are. Dr. Vlahakis, you may still be on mute.
There we go. Can you hear me now?
Yes, ma'am.
Beautiful. So welcome, everyone. Thank you so much for joining us today. We are very excited to share this presentation with you. It has been a labor of love of this entire team to try to pull together for you what we're learning as we're doing this project, specific to all the things that we're gathering on chronic care management related to barriers, challenges, and also possible solutions. Here we go. So this is me. I'm Joelle Vlahakis. I am a contractor medical director. I'm team lead for this Innovations Challenge Grant project. And my background is in internal medicine, pediatrics, hospice, and palliative medicine. I had a lot of experience, unfortunately, during the pandemic, witnessing firsthand the disparities within our healthcare system, things that weren't completely new to me because I had worked in rural health before, but unfortunately were quite new to some of the physicians I work side by side with. I want to just make sure everyone understands that I am a clinician first and foremost. I'm not a billing and coding expert. Obviously, I live in that world and want very much to convey as much information as possible. If I don't know something that you ask of, I will ask my team to weigh in. I may try, though, to answer the question just to make sure I understand what you need. I'd like to introduce my, collaborator and co-conspirator, Pragati Singh. She is gifted and talented. She is a population health specialist that's devoted to our project. We're borrowing her from NTT, but I want to let her say a little bit about herself before we get started.
Dr. Vlahakis, Pragati is having just a little technical difficulty. I'm chatting with her at the moment, and I will let you know as soon as she is available.
Well, I will keep going for now, and I know I have confidence that she'll be able to join us soon. But Pragati is one of the few people I've met who match me on passion for health equity and the desire to have a multidisciplinary approach to that space. She has over 20 years of experience in healthcare. She is a strategist primarily. She's also incredibly wonderful at operations, and she understands that if we don't manage the practical, no matter how theoretic our project is, we will not get anywhere. And that's where you all are here today. Let's see if we can. There we are. Yeah, it's a little slow today Here we go. All right, now we've got it. So what is chronic care management? I'm going to start basic. It was introduced by Medicare January 1st of 2015, and the idea was to reimburse physicians for non-face-to-face care coordination for Medicare Part B beneficiaries with multiple chronic conditions that they weren't getting payment in other structures, such as an accountable care organization or others or other service-minded program. The idea is to manage the patient through support with the physician. It may be through clinical staff. It may be through other qualified health professionals. It may be within the confines of community. But the idea was to utilize what we had and get reimbursed for that brain drain that we have during the day where we're running between patients and people are asking us what to do to avoid crises or in response to crises. And Medicare said that had some value and they wanted to assign to us the opportunity to reimburse. It is a holistic plan. It is designed to look at the patient in terms of all their medical conditions, as well as their psychosocial needs, their functional status, activities, daily living. It is comprehensive. So what does that look like? All right, so to break it down just in terms of highlights, it does mean what it says. It is a comprehensive set of services that's really based within a care plan, and their care plan could be considered a structured recording of patient health information. It encompasses patients in all axes, who's their caregiver, what medications are they taking, what other sources are they accessing for their health care, such as hospital stays. It really hinges on that comprehensive care plan, which is generally needs to be electronic and pass certain requirements. Managing those care transitions, which doctors always dread but are getting better at, that the care is coordinated within and outside of the practice, that there's a continuous patient relationship within the care team, that all of those folks are supporting the patient to achieving their goals. This is very important and sometimes tricky to do, but there's 24/7 patient access to their healthcare and healthcare information. This is beyond a call system. This is beyond a typical patient portal. And we've talked about this often, and it may come up today. And we want to make sure that the patients get their preventative care because this is, after all, a holistic model. It's a proactive model. We don't want to wait till patients get crises. We want to head those off if we can. We want to make sure that we manage the patient in terms of their family structure and who their caregiver is. And we want a high level of engagement of that caregiver if that's relevant. And then we want to be able to share that patient information, not only with other providers, but with the patient themselves. All right, so who can get chronic care management? We want to make sure patients have 2 or more chronic conditions that are expected to last at least 12 months or until the patient dies. And these chronic medical conditions place the patient at higher risk for death, acute exacerbation, which might be evidenced by hospital stay or emergency room visit, places that patient at high risk for functional decline. And that includes cognitive decline. And you'll notice, in addition to chronic care management, we also include complex chronic care management, which means patients who are a little bit more complicated than your average typical patient. That allows you to get reimbursed at a slightly higher rate and allows you to, again, get value assigned to that the brain space that that patient requires as you're managing crises or preventing crises. Principal care management is a really good thing to know about, especially if you're a specialist. It allows patients with a single high-risk condition witness something such as a cancer diagnosis, which may have a beginning and an end, but certainly does place the patient at high risk. It might require frequent adjustments to medication, and it might be especially challenging to manage because of other comorbidities and need to collaborate with other specialists. And of course, it's expected to last at least 3 months or until the patient may die. All right, so just to try to root this in what I was saying before, the required elements of chronic care management are the eligibility that we just talked about, but also consent. And that can be a bit of a barrier. And I really want to make sure we have a chance to explore that. We need to make sure that if the patient hasn't been seen in the previous 12 months, that you have what's called an initiating visit. And it's hard to imagine that these patients with a significant chronic medical condition or two or more chronic medical conditions wouldn't have been seen within the last 12 months. Perhaps they're new. Regardless, an initiating visit is encouraged and required of this program. Also, a cornerstone of this program is the care plan. This is something that is often very unique to other folks that aren't physicians. Many of you are very adept at care planning. Those of us in hospice have used care plans. We've learned how to do those from nursing staff. Rehabilitation often uses a care plan. Well, Medicare recognizes what value this can assign to a patient's general well-being, and they ask that we construct one in this program. In addition, one has to be prepared if you're going to start to use chronic care management to supply time and documentation as required in order to be reimbursed for providing this really well thought out service. All right, so why would you do this? Well, for patients, there's a lot of benefit. Certainly, this is a different approach to care. This is not problem focused. This is a holistic, proactive focus. This is very different than many of us have learned in medicine, where we have a problem and we have a response. This is really looking at the patient from a holistic point of view. What can we do to avoid problems, avoid crises? It's also a strengths-based model of care. So rather than focus on what we don't have for the patient, what do we have? Maybe we don't have, for example, a single caregiver, but maybe within the confines of the family and community, maybe we can put together what I would call a quilt of care providers such that the patient is getting his or her needs met. When patients enroll in this program, we notice that they have fewer emergency room visits and fewer hospital stays. And I don't know about you all, but hospital stays and emergency room visits are extremely disruptive. They're generally upsetting. They're generally precipitated by a crisis. No one likes to be in the hospital, no matter how nice I was or how good the food was in our hospital. And I'm kidding about that. People do not like to stay. There's a lot of depersonalization that happens in hospitals, as we all know. We don't even get to wear our usual clothes. Our whole environment has changed. We're not near our pets, our family, the things that are important to us. Also important for patients is overall, you have lower out-of-pocket costs. And this is important. We'll talk a little bit about why we might need to point this out to patients as we're looking at barriers. All right, so if this is so great, then how come everyone isn't doing it? Why is there such a gap between the folks that could get it and the folks that are getting it? And we're going to share this next set of slides with you, which will demonstrate that pretty starkly. So if this were so easy, everyone would do it. What are the barriers and challenges? Well, we've identified some general categories and we've come up with a list. This is not a comprehensive list by any stretch or imagination, but it is what we see over and over again as people identifying as really challenges to get this program underway. The first are patient related. How do you identify those patients? How do you get your system to let you know that they might qualify for this? How do you onboard them? How do you get them to buy into this? Consenting patients for the program is specific and needs to happen. And then costs. there are patient-related costs to this, coinsurance and cost sharing. And how do you get patients who perhaps were used to calling the office and not having to pay anything for that service, suddenly now having to pay out of pocket for something that they thought was just part and parcel of what you normally do? How do you convince them to do that? And then, as if patients weren't more challenging enough, I think providers are also very challenged by this. It's a different way to practice. It's a different way to think about patients. How do you get your time accounted for? And do we have the staffing for this? No one that I've met lately has too many staff in their office. How do you manage this, and especially in times of staffing shortages? And the data entry. I already enter so much as it is. I was very concerned as a provider, to be honest with you, when I initiated this project. How could I possibly ask my fellow physicians and other healthcare professionals to do more right now? We just got through a pandemic. There's so much that people have to worry about. We keep adding new things on the list of things we have to prevent for patients and talk about, and then the visits get shorter and shorter. How could I possibly ask for more? And that's something I want to make sure we talk about. Within the community, if you're managing patients, especially in that space where there may be some significant health inequities, where access even to food is challenging, how do you make sure that you have the resources to support this program? Because it does rely on outside resources. How do you not only identify them, but then how do you partner with them? And we'll talk about those issues. And then within the system itself, there's always a lot to change, right? When you're changing the way you think about practicing. The system is certainly no different. It doesn't want to move either. That electronic medical record may not be very adaptive. And then if it is, there may be costs assigned to making those changes in your electronic record. Time capture is always challenging. Sometimes our interactions are very fleeting. How do you do that in an accurate way? How do you make sure it's comprehensive? And then do you have the opportunities to make sure that you're had some double checking on all of that? And then your billing and coding. How then do you communicate in terms of your system with billing and coding such that you're able to assign value to that and then pass it along for reimbursement? All right, so who are we and how would we know about all these barriers and challenges? Well, some of it's our own experience. As I mentioned, several of us have come from the outside looking in and we know from our own experience some of the ways in which we've been challenged by this program. We've had lots of interactions at this point in the project with other professionals, other organizations, certainly physicians, and most recently, we've sat down with a group of physicians and talked in a very intensive way about these programs and got a lot of really good insights from that group. And then really from a lot of the people who are attending today, your questions, your concerns, pre-submitted questions, questions related to other uh, educational offerings we've had, to things that are stimulated by some of the YouTube videos that we have and other pre-recorded sessions. You all have been extremely generous in letting us know what's on your mind, and we've used that to try to stimulate our own learning about this program. All right, so I promised that I would share with you where we are with use of CCM and how we might be able to get better. So we have wonderful data scientists at WPS, and we asked them to let us know, hey, you know what? In 2022, how many of our Medicare beneficiaries that we cover in our 6 states actually have 2 or more chronic conditions? How many would, at least theoretically, qualify for using chronic care management? And I don't think anybody on this call would be surprised to know that the majority, that is about 2/3 or more of our patients that we cover as Medicare beneficiaries, have 2 or more chronic conditions at any one time. All right, so let's take a look at how many are actually using chronic care management. So I was recently in Missouri, and I was recently in a event that was centered around liver disease. So just for grins, I asked our data scientists, hey, can you let me know about how many claims we are generating for this particular group? So in the entire state of Missouri, how many of our patients with a diagnosis that requires visits to a gastroenterologist are on CCM, or chronic care management? So they estimated somewhere when we peaked around 300 patients were receiving chronic care management if they were also seen by a gastroenterologist. So where does that put us? So we've highlighted it here for you just for ease of uh, understanding, but it puts us at about 2.5% of beneficiaries in Missouri who have a diagnosis that warrants going to a gastroenterologist, which probably means they have at least one chronic medical condition, likely more, are actually getting chronic care management. And I think that's the space in which my team and I reside. Why aren't we using this program? And this talk really spurred from that question. How come more people, more providers, more patients aren't availing themselves to it? What is hanging this up? All right. So a little bit about the challenge grant and my team. Our goal is to really get more folks to use this. And we've got a modest goal. We want to increase the use of these services by 5% for all beneficiaries in our jurisdictions when compared to the previous 12 months. And you can see we have a long way to go. So 5% is modest. We'd like to increase claims by 2.5% when we look at beneficiaries who are in areas of high deprivation. That is to say, they're perhaps food insecure, they're housing insecure, they may have less income, they may have not as good air or water quality. This is this ADI, or area deprivation index, is something we use as a surrogate to explain or demonstrate areas where there may be a high degree of health inequity. And then we'd like to decrease emergency room visits by 1% in our first year. Again, a modest goal, but something that would allow us to feel like we're really making a difference. So if it's all right with the team here, I'd like to talk a little bit about a case. And I'd like to use this woman to illustrate for us how these barriers stack up as she's navigating the system. So let's meet Ella. She's not on a Medicare Advantage plan. She's on straight Medicare. She's 66, so she's new. She has type 2 diabetes and hypertension, and as a result of these two illnesses, also now has chronic kidney disease. And her daughter works in a physician's office, and she's been bothering her mother for some time to, quote, get established with someone soon, because she's not gone to see a doctor in several years outside of urgent visits. And this is largely because she was caring for her husband with cardiomyopathy, and that was a full-time job, and she couldn't manage to attend to her own health as well. Unfortunately, she's recently widowed from this husband, whose income was her main source of financial support. And she's now home insecure. I'm going to now allow, if technology will support us, my colleague Pragati to talk a little bit about the system in which Ella finds herself. Let's see how good we are.
Are you able to hear me?
Yes,
Yes.
we are.
Yes.
Okay. Hopefully I am not echoing. Thank you so much for being patient. A few audio issues this morning. So to build on what Dr. Vlahakis has mentioned, as we understand, there are multiple drivers in our environments that affect our health. We've all heard the term SDOH, social determinants of health. This is, I thought, an incredible graphic that we wanted to be able to share with you, because it really captures the upstream and the downstream factors that end up affecting the way that your organizations are able to provide care delivery. And we are grateful to be in an era where not just the healthcare field, but those outside of it as well are understanding the value of being able to incorporate those into any sort of policy making, model development, and other goals. And the reason that's important is there's only so much that we can burden health systems with. You can't solve all of the problems that are happening for your patients outside of the clinical care system. And so it is heartening to see that multiple other interdisciplinary sort of approaches are being taken to help support the very important work that you're doing that you already don't have enough time to be able to do in the way that you would like. And so the DHHS, U.S. Department of Health and Human Services, actually put this framework out, I want to say a couple of years ago, or maybe about a year ago, in which they approached a strategy to address SDOH in this way. So sort of to capture the upstream and the downstream efforts. It was their approach to hopefully make health outcomes a little more equitable by coordinating various services via this newer approach of whole of government, a multi-sector approach, pulling in those CBOs, pulling in those policymakers, pulling in your local and state delivery organizations in order to help address some of those underlying systemic and environmental factors that end up affecting the health of your patients and, in fact, the health of the health systems themselves. So part of what we wanted to show here is an acknowledgement of what environment you are in as you are trying to do the best that you possibly can to provide good care delivery. And I'll just go a couple of layers deeper here, and then we can move on to the next slide. But what I wanted to point out is we often tend to see really incredible graphics, and then there's not a lot of action behind it. So I wanted to dig a little bit deeper here and share with you, and there's a little more information about this, obviously, on the HHS website, but since we're all here, the deeper two layers of this particular graphic is that there are three goals that sit under it that HHS has proposed. One is to establish interoperability standards. You may have already heard a bit about that. This is really an effort that the ONC, the Office of the National Coordinator for Health Information Technology, has proposed, in which they are working round the clock to work through interoperability standards, what those criteria will be, how that exchange will take place, what they can put into place to help health systems and payers, in fact, become more agile and not place as much of a burden as they had expected beforehand. And so if you are not already familiar, the ONC has actually put out what's called a Social Determinants of Health Information Exchange Toolkit that has practical guides that will help you as you're working through how to implement these SDOH information exchanges. Often what happens is we tend to hear some of these mandates come through, and then it becomes a bit difficult to understand exactly which questions we should be asking along the way in order to be able to meet these newer standards. So they put out this toolkit. It's sort of in its first iteration, I believe. They'll be continuing to work on it, but I wanted to read you a little bit of a list of their intended audience, which sort of helps to understand that they are capturing the larger environment. So this is for government agencies and payers and policymakers, obviously health systems, CBOs, networks of CBOs, community resource referral initiatives, obviously providers, IT platform developers and managers. So they're really trying to cover the swath that you as health systems, and we tend to obviously notice, are involved in how you're able to deliver care. So as we move onward from that goal, the second couple of goals that they have outset, one is that they are working on expanding their community health worker services to address SDOH, specifically because of the exacerbation by COVID-19 that we all experienced. And so what I'm expecting is that there will be continued efforts and initiatives that will be rolling out in order to support health systems along the way. Their third goal is to partner better with other federal departments, enhancing access to safe and affordable housing, access to transportation, and the rest of the issues, and offering some more initiatives around that kind of assistance. So there is a concerted effort beneath this kind of a framework. And so I just wanted to share a couple of examples of that so that this isn't yet another sort of statement or a vision without work being done behind it. I think we can move to the next one. Thank you. So in conjunction with that, again, I'm sure this audience is already familiar, but the CMS Office of Minority Health Director, Dr. McIver, is incredible in the way that she has been able to capture the environment around the patient again. And again, due to some of the concerted efforts by HHS and some of the CMS research that has been actively done and is continuing to be done, what she has outlined is this 5-goal, 5-priority framework from CMS. These are specific initiatives that are being taken in multiple forms. So either pilot funding, you'll be noticing even more grants that will be offered around these specific priorities. And number 3, an effort to build task forces that are either overlapping in some of these priorities or are individually being developed so that there are more and more informed models that will be developed or existing models that will be modified. And I wanted to make sure to share that so that our audience certainly is aware that there is an appetite on CMS's part to hear what is working and also what is not working. That's the underlying goal of this particular framework. And CMS may not have shared that outright, but they're certainly discussing that in panel discussions and internal meetings. And I wanted to make sure that I shared that so that you are more encouraged to offer your feedback. It is something that is being taken back to CMS. It is something they are paying attention to, and it is the driver of these particular priorities. Next slide, please. So how do we identify who those patients are that need the most help in terms of SDOH resources? Your health systems are sophisticated. You have been handling this issue well before the term came into existence. So this is yet another tool that we have come across that we find extremely helpful, that we have certainly been utilizing. And so this is an effort just to share resources. So let me talk a little bit about the ADI and how it came to be. So the University of Wisconsin-Madison specifically, engaged in an effort with HRSA, so the Health Resources and Services Administration, to build this specific ADI tool. And the reason for that was that a few decades ago, there was discussion, quite a bit of research around what is now considered the ADI areas. And so Dr. Kind and her research team at the University of Wisconsin-Madison decided they wanted to focus on census block groups rather than looking at large regions, which often tend to miss some of the outliers, which is really where a lot of the answers to what those resources that are needed are. She ended up working through the neighborhoods via the census block groups in order to break down and categorize by socioeconomic disadvantage, by state, by county level, under the factors of income, education, employment, and housing quality. So in this particular tool, which I believe Ellen has already shared a link to, you can drill down to your county level. And a couple of things to note there. What you can do is request how your county ranks as it is compared with the remaining counties within your state, or how it ranks according to its ranking across the nation's counties. And those are two different sort of toggle buttons that you have available. And I'll just sort of share why I found that to be important. Number one, if you are focusing on what's happening within your state, certainly you'll want a state-only ranking. If you are submitting for a grant that is a federal grant, you're responding to a federal RFP, it is extremely valuable to indicate where your county is ranking across the U.S. so that there is more of an impact to those that are reading through to say, wow, you really are in an incredibly high percentile ADI area. You are more prioritized for this particular grant fund. And so I wanted to make sure to share that a bit, because this has been highly utilized by, excuse me, by several who have been taking a look at how they can use this data and supplement it with their own health systems data for some of these pilot initiatives that are offering funding that is extremely helpful and doesn't tend to require as much investment from your health system, and rather can be there to support your existing efforts. So I'm hopeful that this is important and helpful. It certainly has been, as we mentioned, helpful as we're taking a look at who we're serving in our jurisdiction so that we can help to prioritize who we are reaching out to in a manner that is well informed of the community that they are particularly serving. So I'm hopeful that between this and some of the other resources that HHS and CMS are working on, and that we are certainly keeping an eye on, that you will continue to share more and more of what is and is not working, because our goal obviously is to make sure that we're working in tandem with you to better understand what barriers you're experiencing and also what best practices you are putting into place to overcome some of these challenges as well. So with that, I will turn it back over to Dr. Vlahakis.
So I encourage you to put your smartphones on camera mode and go ahead and get on the area deprivation index. And if you want to be astounded, look in your areas. You can really get very granular with this, and I won't mind at all if you play around with it while we're talking right now, because it's really instructive and interesting. Okay. Okay, here we go. So let's get back to Ella then. So let's talk about where she is in terms of the system. So let's say that we are really astute, and when she checks in and the nurse takes her back to the room, she's able to identify Ella as a person who would qualify for chronic care management. Can we explain about the program in an understandable way? And let's talk about consent. It is important how we obtain consent from the patient and why. I had a question from one of my colleagues about why do we even need to consent for this program? It's such a good program. And I thought it was really a good question. So let's talk a little bit about it. All right, so how do you even identify patients? Well, there's been a lot of discussion about this because it seems at first glance to be a barrier, but what I'm finding is there are almost as many ways to do this as there are different practice types. So some practices will have some form of trigger that allows the patient to be identified electronically, perhaps due to a claim or two in the past. There are practices that will look at the roster of patients to be seen each day, and will get us able to, at a glance, be able to determine that this patient would fit or not, or at least put a note in to have the physician or provider take a look at that and consider the patient for the program. You can do an intra-office referral, meaning that someone at the front receives information that someone was hospitalized, for example. There was an emergency room visit, and that can be a triggering event. Some multidisciplinary practices are able to identify patients simply because they're going to so many of the different specialists. So you can consent that person in real time verbally. You can do it by phone in a follow-up call. So even if you introduce the concept at the beginning, you can, and they're not sure, you can follow up with a phone call. It can be written as well as verbal or a combination of both, and we'll talk about that. One thing that we did learn when we sat down with providers is that it's essential that the program is explained in an understandable way. One of our physician leaders said, educate, educate, educate. And you might have to do it multiple times in order to get patients to agree. Another resource, which is really important, and again, if you'd like to use your smartphone to access the CMS MLN booklet on chronic care management, this is written for all, and it can be something that you can send your patient home with or let them look up online if they're savvy enough. It can at least legitimize the ask. And why do we need to do that? Well, when we're asking patients about this, there can be quite a lot of dubiousness. All right. Like, why are you asking me to consent to this program? What's in it for me? What's the catch? There is a lot of skepticism, and a lot of patients are very educated about fraud and abuse of the system, and they may be concerned that this is just another form of that. If you, importantly to know, if you do consent verbally by phone or in the office, it's important that you get a written consent signature the next time the patient is in the office. It can also be a consent given by a caregiver if the patient is not able to consent on their own. It needs to be in written form, but that can be electronic or paper. So why do we need to consent patients in the first place? Well, we need to make sure that they know it's available, but there are costs involved, and the copay can be a hurdle. But I have a very astute team member, and Ellen has done some cost comparison and has been able to discover that one hospital stay requires so much in terms of co-insurance from a patient that it could potentially cover 60 months or 5 years of chronic care management. It's important to consent because we need the patient to understand that only one provider can furnish and bill for chronic care management or complex chronic care management each month. And we need to make sure we've had that conversation. One of our most common reasons for denial is simply that two providers have billed for the same service. And we also need to let the patient know that they have the right to revoke the service at any time. All right. So, providers. How do providers consider this program? Well, a lot of them are like, really? I don't have the time to learn something new. I don't have the time to document this. It puts me at risk for denials, for accusations of misuse or fraud. Patients will often wonder why the provider is requesting payment for a service that at this point, perhaps they've been getting all along without the need for a co-insurance, such as a phone call and the like. Providers also worried about losing control. If I allow my clinical staff to weigh in on the details of the patient's care, will I be able to really manage what's happening for the patient? I don't want to do that. I want to make sure I know what's happening all the time. Well, why would a physician do this? As I mentioned at the beginning, I am a physician and I worried very much. My mind was preoccupied with how could I ask physicians to do one more thing when they have already been asked to do so much, especially of late. Well, I liked the idea that there's value assigned to an activity that physicians tend to do rather fluidly and well behind the scenes. Getting reimbursed for the brain space that you afford a patient so you can avoid a crisis for them, that is valuable. It also contributes to less fragmentation of healthcare if you can avoid a patient going to the emergency room in the first place. And if you're not managing as many crises behind the scenes because you have these very ill patients well managed, you potentially have more time for in-person visits. And some of our providers have told us that that is a bonus they didn't expect. Some of them have also expressed that when they are able to relinquish a little control, they grow very appreciative of the skills of the clinical staff surrounding them and what they're able to do to enhance the care of patients and families. The providers also tell us that many times the clinical team then becomes a real extension of themselves, and that patients feel more connected to them, even though they're relinquishing some control. So overall, it can be a much better experience for physicians and providers and provide for what I call an enhanced quality of work life, which I believe is important. All right. So as a provider, how would I begin on this if I've never done it before? Well, one of the tenets we've heard over and over again is to consider starting small. Consider starting with a subset of your most ill patients. That is to say, those patients that you think might be most benefited by this program. Maybe you start with one diagnosis or a group of diagnoses. This can be helpful, especially if you're specialists. Many of us already know. We can name off the top of our heads, perhaps our 10 or 25 most ill patients. If you're not sure, ask your front office staff because they're going to know who calls the most often. If I were a provider, I would then start collecting resources about chronic care management. I've put on there the QR code for our chronic care management playlist. This will take you right to YouTube and will give you no fewer than 15 collected educational sessions, some of them short, some of them as long as an hour and 20 minutes, that will allow you to learn a little bit more about chronic care management from a group of folks that I respect very much, members of my team who know a great deal. There are also professional societies that you may already belong to as a provider or as a physician extender or non-physician provider. The American College of Physicians is something I belong to as an internist, and they have excellent resources about chronic care management. In fact, they came out very early on in 2015 with some great resources, and they've updated them. The American Academy of Family Physicians is no exception. They also have excellent resources and actually some excellent slide decks about doing chronic care management. They have a toolkit, and I think both of them are worthy of a look. I'll stop there. There are more, and I've also included some articles and other written materials at the end for support for providers. All right, so we've talked about patients, we've talked about providers. I know this is not an exhaustive list by any stretch, but I want to stimulate our discussion. I also want to mention, please start sending us your questions. We want them, even if we don't have the answers right now. We will always get back to you with some form, and we can send it to all. It also stimulates us to our blog posts that we do and future educational offerings. You all have the most interesting, amazing, insightful, unpredictable questions, and I can't wait to get to them. You also may have some of these barriers that you yourself have faced, and perhaps you and your practices have figured out ways to break through them, and I want to hear about those too. So in terms of clinic, I think one of the things that comes up over and over again in office practices is who's going to document the updates to the care plan. This is a big document. We don't have the staff to do this. What do we do? How can we possibly meet the need here when we're not equipped or we don't feel we're equipped? All right, so some of the ideas to consider. Again, identify one staff member to start. This is just a slight difference in the idea to start small with a small group of patients. Start with just one of your clinic members or staff members. Assign them only a very few patients. It's good to choose that particular social butterfly on your office team, someone who relates well, whose warmth comes through on the phone. Make them the expert in chronic care management. They're not going to do it exclusively. There'll be other members of your team perhaps who will weigh in. But if you have one person who's even just curious about this program, it can be a great way to initiate CCM without overwhelming everyone. No, of course, there are external organizations who do this. You can acquire a contract, you can partner. There are requirements to using a chronic care management service that's outside of your practice. And that CMS is pretty strict about. So we can talk about those. Some people have great success using a service. Many of our providers prefer to use someone who's already in their office because they feel that that engenders trust with patients. It also engenders more communication within the office practice itself. But again, there may be some advantages, especially when staffing is an issue, and it's probably better to do it at all rather than worry about doing it to perfection. And then consider making chronic care management a quality improvement project. This can be great for those of you who work within a healthcare system and may have some administrators you also need to please. Quality improvement projects are a great way to pilot something small like this that may have a great impact on your practice. You can begin very small by trying to interact with your electronic health record. And that is a very good way to systematize chronic care management for all. And then as time wears on and you have some success with this, and you'll know it when you see it, you can start to educate your providers about what it's like to do this kind of care and the benefits that you're seeing. All right, so within the system related challenges. Again, this is not meant to be an exhaustive list, but these are things that we see and hear most often. Time capturing. How do you time capture such that you can reach that threshold of 20 minutes for chronic care management and higher for complex chronic care management? And then how do you document to that? How do you make sure that Medicare knows when you bill that you're not simply billing because you ran a list of patients who need, say, the flu shots this month? No, that you are responding to something that drives patient care. The pharmacist connected with you to let you know about an issue with the patient's medications. The patient themselves connected with you because they're worried about some parameter or someone was exposed to COVID at home. Those kinds of things. You need to be able to bring it back to a patient need or a patient change in their care plan. Another thing that is a challenge is documenting all of that. Where do you put it? How do you manage it? And we'll talk a little bit about that. And then, of course, we've had some concern, and we will actually have an entire session on this, how to manage when your claims have been denied, how to figure out why that's happened. What are the most pressing issues and common causes of claim denials, and how to avoid them. All right, in terms of system, when you think about your providers, administrators, clinical staff, you may find that putting together a task force or what I call a core group of chronic care management champions is a good idea. Some of our multi-specialty larger groups found that this was really key to getting this implemented. In fact, they had to climb that mountain a couple of times, but they've also told us, quote, once you get over the hump, it's totally worth it. Some of these champions could be attending a webinar about how to implement this, educating themselves, getting a little more confident. And then if and when there are claims denials, reach out to find out why. And then attend our webinar that we're going to have about our most common claim denials for chronic care management, which we're putting together again for you based upon things that you've told us. We're not including that here right now because we know it's going to be an entire session on its own and we don't want to give it short shrift, but we do want to hear what your experience has been. And then anticipating time to full implementation. Understand that this takes some time and that you might not feel successful right away. Again, this mantra, it can take some time, but once you get there, it is totally worth it. All right. One of the really important parts about chronic care management is the use of things outside of a traditional clinic setting or office practice. It can be really hard when you have been practicing all along in your, I'll say, little world, managing perhaps very well medications, medical problems, problem lists, cognitive decline, and the like. To suddenly think about, well, now I have to know what's available outside my practice. And yes, one of the tenets and most basic pillars upon which chronic care management relies are community-related resources. So question number one that we get hit with, I don't even know what's available. Well, we know and we understand that, and we have some potential solutions for that. Another question or comment we get is we don't have a social worker in our practice. We're too small. How are we supposed to coordinate all of this? And then another, I practice in a really poor community. We're rural based, or perhaps we're in a place where there really isn't a lot available. We don't have a lot of resources. Where are we to turn? And we've heard this all. So I think starting small and being creative is a great way to initiate this. That clinical person, that staff member that you said, hey, I think they'd be really good at this. If you can assign that person or someone near that person the challenge of trying to find out what's available and starting to build a database, that is an excellent way to begin. Think about non-traditional partners, such as community health workers. They're in a lot of environments, especially in those that might have a high ADI or area deprivation index, or have a good amount of health inequity. I've included this Tool 11 Community Resource Guide. Forgive me that I've placed something in here that's specific to a diagnosis. It's a cardiac care plan, but it's so well done. I wanted you to have it so it could give you some food for thought. The idea about developing partnerships, people around you, community-based organizations that you might not have thought of before. There are some really interesting things happen out there related to food insecurity and food deserts. There are folks who are partnering, say, with our state and local parks to develop some really interesting ways to demonstrate food planning with things like fresh fruits and vegetables. There are organizations out there that provide transportation. I know, for example, in my community, the American Cancer Society helps to bring patients to their cancer appointments, which may add up, especially if you're doing both chemo and radiation. People don't often think of it, but as someone who grew up in hospice care and learned a lot from them, a lot of community-based hospices have bereavement groups, and you do not have had to have used hospice services in order to be part of a spousal group loss, for example. Faith-based communities can be a wonderful source of places to partner. Things that like parish nurses, for example. Think about partners you might not have considered previously, like Habitat for Humanity. One practice hosted a men's group. What I love about this is they became active participants, and you can really add a whole nother dimension to your community involvement when staff become volunteers. And what we've seen is a lot of this happens very organically, that staff members who may be starting to collect these resources become really interested in, oh my gosh, I didn't even know this was an organization. I really would like to see what they're all about. And they may give up a day on their weekend to help build a house for Habitat and Humanity. And what a wonderful team building exercise for your clinical practices. And then think about if you happen to be blessed and working in a larger health system that might have utilized social workers, could you pilot a program or share a position with a non-traditional clinical team member once a week, for example, or even a couple times a month, who can work with your patients directly and or your staff to help bolster their efforts and connect to community resources. Am I getting you excited about this yet? I hope so. There's a lot out there and a lot of really creative ideas. These are not from me. but I've learned and watched and seen a lot of amazing things happen out there. And I just want to give you some hope and some optimism that you can do this too. 211 for help is a great place to start. Depending on your community, it may not be the place to end. If you find that this isn't helpful, apologies, but there are also some web-based resources which I'll share with you. So if you happen to live in Iowa, Nebraska, Kansas, or Missouri, we're giving you these slides. These are places to start in terms of your web resources. If you live in Michigan or Indiana, we've provided you with some additional places to start. All right. And I'm going to tell you, I mean, I could talk about this for another hour. I want to make sure we have plenty of time for questions and for you to ask my team, who's collectively far smarter about these things than I am, your questions. But we want to let you know about some things we're doing up ahead. I mentioned, perhaps this is a teaser, but we're going to have our discussion on the most common reasons for denial of chronic care management claims. I think that will be really worthwhile. A real examination of this, and hopefully it'll help us all be more successful as we move forward. We have a lot of chronic care management resources on our website, and we also produce a blog, our WPS Medicare Buzz. And I'm going to start writing two, actually, one on how to share a care plan with the patient when your patient has low health literacy, because that's really an issue. And although I've been told by my colleagues that when you give your patient a written care plan, it can be extremely powerful. They have no idea how much you're doing to care for them, and it can also help them partner in a meaningful way. But when your patient has a low health literacy, it can just be another source of frustration, and they aren't able to adhere to the plan that you've so carefully rendered. Another one that I want to do is an examination of care planning. You know, I spent the last decade or so working as a hospice medical director and as a palliative physician. I've learned a lot about care planning, mostly from my nurse colleagues. They are the ones who demonstrated that for me. My social workers help fill in the gaps. A wonderful care plan document is interdisciplinary. It's not necessarily based solely on a physician. Physicians don't think like care planning, as one of my doctors told me. And I want to write a little bit to that. How do you learn to care plan as a physician? And then we'd like to offer at some point in the future chronic care management grand rounds, where we actually highlight a case and talk a little bit about the Ellas of the world and how they can manage going through this system. For example, you can imagine really well that someone recently widowed might benefit from hospice community resources widows group. Someone who's food insecure might do really well with the food pantry. Someone like Ella might need a discussion about who do you have at home, and if you're home insecure, are you going to live with your daughter? Do you already live with them now? What's that like? So we want to have a little more examination, and we're going to highlight cases brought by you all. Another thing we're really excited about are virtual sessions we've planned over the next 2 months. One is actually next week, and the other will be in June. We have a physician-centered discussion. We're calling it a roundtable, but we have transdisciplinary support. So we have our population health specialists and our billing and coding experts at the ready to help that discussion along. It's an honest reveal of barriers and frustrations, and it's bi-directional, meaning that we sit down together. We not only talk about the challenges, but also potential solutions. And it's a conversation. And we invite folks of all levels of mastery of chronic care management. We have some folks with hundreds of patients enrolled in chronic care management, and some that are just wistfully hoping they can initiate it soon. They're just trying to convince their administrators it's a good idea, and they want to know how. There are all kinds of different environments that our physicians who come to these roundtables practice in. Some of them are specialists, actually. Some of them are rural, urban. Some of them practice in areas of high area deprivation, and others practice in more affluent areas. We've got them all, and we're all struggling trying to figure this out. So these are the dates. just, you'll be the first to know, we're going to have to move Saturday, June 3rd to Saturday, June 10th. We've realized that it coincides with the end of the Memorial Day week holiday, and some people are out of town, so we're going to accommodate them a little bit. I've left my cell phone number there, as well as my email. We really want to hear from you. If you aren't a provider or a physician and you'd like to participate in a roundtable or an advisory group to the project, let us know, because we will be actually using the roundtable format for some other folks as well. We're really excited, for example, about having a group of population health specialists come and jam, as I like to say, about this program and how we can make it better. One thing that my colleague Pragati mentioned to you is that CMS is very interested in what we're discovering in this innovation project. And it's really important to us that we give voice to some of these challenges and barriers because they're universal. And when we know these things and we can bring them to CMS with some potential solutions attached to them, that is extremely powerful and may affect some substantive change such that our Medicare beneficiaries are able to get the benefits of these programs, that we remain really good stewards of Medicare trust fund, because we know that that's not bottomless. And the best way to spend that down is to require a hospital stay and have to cover that for an emergency room visit. We'd much rather keep people out of the hospital setting, and our patients would prefer that too, as would our physicians. So we want to know how can we do this better? All right, so as promised, I wasn't kidding about this. We have some links provided for your convenience. We wanted to make sure that you left this with something. We don't know everything. We've probably given you more things to think about, more questions than we've given you answers, and that's okay, because we want this to be an ongoing conversation. But here's some tools to get started. We've mentioned how to collect the resources. I've got that in there. Someone who's a colleague who I reached out to because he was, unfortunately for him, given a whole write-up about how he manages chronic care management. He's really our resident expert, and he attends almost all of our physician roundtables. He's really an exceptional human being, and I encourage you to take a look. He actually practices in rural Georgia, a solo, but this is his YouTube video, and it is just precious. It's really about how to and how not to consent a patient and explain chronic care management. So if you want to learn how not to do it, he has several very fun scenarios about that. Of course, we've given you the link to the CMS MLN booklet on chronic care management. That's our Bible. We have a playlist on chronic care management for you. I've given you the link. It's an active link to Medicare Buzz. And then the toolkits are here. Now, these may require a membership and or fee, but if you already belong to these particular associations, I would encourage your providers to take a look-see at these toolkits because they're really worthwhile and they're very helpful. Articles for further explanation. Some of these are on the ACP or American College of Physicians website. Again, you might be required to be a member in order to access them, but they're really great little articles. They're a quick read. And then I've included some things that are a little bit more substantive. I just use an example of hepatitis C as a way to demonstrate the use of chronic care management. And then some of these other articles, some of these are opinion articles, but I wanted to have both articles that really promoted use of the program, and then an article that was written early on that questioned the program, because I want this to be a balanced discussion. And then there's a fee schedule. That's just for comparison's sake. Everyone's jurisdictions are slightly different. And I'm actually starting to see some questions pop up. This is our survey for this particular session. please let us know what you think. I know we're not quite finished yet, and I'm so excited because I want to get to questions. But you would do us a great service, and we would consider it an honor and a privilege if you would spend a little more time doing the survey. It's pretty quick. All right, I'm going to actually stop my screen sharing so we can do some questions. Let's see here. Oh,
Okay, Joelle, go ahead and keep that up. We are
Okay,
just a little bit, we are just a little bit over on our time. One of the questions that we have received is, are you only looking for physicians to join the roundtable, or can it be staff?
so we are going to have a roundtable for staff. In addition, if you would like to join the physician roundtable, please let us know. We are doing it in a different way. But initially, our roundtables have been for physicians because we want to get after the core reasons they're not using the program. And we know they really do require a little bit of safe space in order to reveal some of those things. But we want your participation, and I'm very excited if you want to help us figure this puzzle out. Why is it that about 2/3 of our Medicare beneficiaries could potentially qualify for this plan, and yet so few are actually receiving it? So yes, please let us know that you want to participate, and we'll figure out a way to get you included.
All right, thank you, Dr. Valhakis. And we are out of time for our presentation today. In fact, we've gone over just a little bit. Just a couple of housekeeping things. If you do have further questions, then we provide an email address there where you can send those questions, and we can take those for 10 days following today's event. If you would, in the subject line, just put today's event 5/11, and then CCM, barriers and challenges, and then the staff that monitor that web or that email box can then send it on to us. We will have a publication of this encore presentation. You'll be able to find that on our website under our training section under encore presentations, and we will also publish information when we get that out there. We do anticipate that this will be out there probably Monday or Tuesday of next week. So we really just want to thank everyone for your attendance today and for kind of hanging with us. The information that Dr. Valhakis and Pragati provided was absolutely fantastic. Thank you very much, and you can now disconnect. Everyone have a great day.